Yes, dear Chairman, Felix, Professor Lange, here is somewhere around. Thank you very much for the invitation to this talk. Although this hen or chicken or egg talk seems to be a little promising, and I have no disclosures so far. As we all know, when we have acute fast ventricular tachycardia, this will lead to acute heart failure, like in this patient who was evaluated for monomorphic VT after tetralogy of Fallot, and you can see that ventricular function deteriorates in this patient. And the same is true if we are looking at bradycardia. So we have here a kind of natural history study in patients with congenital AV block. And you can see that even before they are alive, they are dying because of high drops, low heart rate, leading to end of these life in these fetuses. And the same is true if we're looking at bradycardia after heart surgery. And this is one of the early studies from patients who were operated for different congenital heart defects. And you can see that those patients with complete heart block do die much more likely than those who do not. And if you look further at the patients who have an AV block after the surgery and survive initially, about 45% of them will be in cardiac failure, and eventually 2/3 of them are dying. So for these two entities, it's very easy, I think, to say if we have fast VT or if we have permanent AV block without pacemaker, here arrhythmia will lead to heart failure. Interesting will be the question, what about tachyarrhythmias and chronic heart failure? So during the next minutes, I will lead you through some different diagnoses, starting with the tachycardia-induced cardiomyopathy, because tachycardia-induced cardiomyopathy seems to be not too difficult to answer. So here you can see the chest X-ray of a boy who presented 5 years ago with a left ventricular ejection fraction of 15%, high right mitral regurgitation. And this patient actually had an ECG showing tachycardia about 155 beats per minute. And you can appreciate, you can appreciate here that there are negative P waves. You have a long RP interval in this tachycardia, which is quite suggestive of PJRT or atrial ectopic tachycardia. And that was what we found when we had an EP study in this boy. And you can see that here in white, the earliest atrial activation of this slow-conducting retrograde fiber from the PJRT is here at the os of the coronary sinus, and ablation here could abolish tachycardia. And this is actually what we see during follow-up in this patient. Thank you, Dr. Kersel from Brandenburg, for these pictures. You can see that about 1 year after the ablation, the left ventricular anti-systolic diameter normalized, and the fractional shortening also normalized. So this is typically what we see if we have patients with PJRT. About 20% of these patients will be in tachycardia-induced cardiomyopathy, and after regression, after effective therapy in these patients, you will have normalization in nearly all of these patients. And the same is true for atrial ectopic tachycardia. You can see in this slide here that a lot of these infants will spontaneously resolute over the first year, but if they do not, it will stay, and then it also will be resolved with therapy, either antiarrhythmic or ablation therapy. So tachycardia-induced cardiomyopathy is a reversible LV dysfunction, absence of an other etiology, and the main cause of this arrhythmia, though, is atrial fibrillation. Atrial fibrillation is strongly associated with heart failure with reduced ejection fraction. So about 20 to 30% of the patients with AF will have HFrEF, and about 10 to 50 patients with HFrEF will have atrial fibrillation. So heart failure will lead to atrial pressure overload, atrial enlargement, scarring, and fibrosis, and actually then to structural remodeling, which will lead to conduction abnormalities with decreased conduction velocities. And on the other hand, if you have atrial fibrillation, this will lead to heart failure due to the reduction of the cardiac output, a loss of atrial contraction, and irregular ventricular filling. What about sudden cardiac death and heart failure? This is a study from Denmark where the authors looked at people below the age of 50, and you see that even in this relatively young age group, coronary artery disease is the main reason for sudden cardiac death. And interestingly, about 50% of the patients who died here didn't know before that they have coronary artery disease at all. So in the acute setting, what you will see in myocardial infarction is in homogeneous conduction, and you will have polymorphic VT. And after chronic setting with the inflammation you will have, there will be in the border zone of the remodeled ventricle macro-reentrant tachycardias leading to the arrhythmia here. What about the atria in heart failure? This is a study from 2003 where you can see carto maps, electroanatomical maps of the right atrium, comparing normals and patients who are in heart failure. And you can see that there is increased scarring, impaired atrial conduction, there is functional conduction delay, impaired sinus node function, and the inducibility and the length of atrial fibrillation was quite longer in these patients than those who do not have this condition of heart failure. What does it mean for our patients? If you look at the ASD cohort, there will be hemodynamic loading of the right atrium especially, which will lead to geometric remodeling, which will eventually lead to electrical remodeling, and this will lead to atrial arrhythmias and conduction disorders. And if you close the defect late, let's say with about 40 years, you will have 10 to 15% of these patients having atrial arrhythmias. And after the closure of the defect, it will go on. So if you close it that age, you will have another 8% atrial arrhythmias 1 year later. And if you had pre-procedural arrhythmia before the ASD closure, it doesn't make sense in terms of arrhythmia to close the defect, of course, for hemodynamic reasons. So coming to the next entity, and we heard this morning about the dilated cardiomyopathy. And in children, though, the rate of sudden cardiac death, and this is from the pediatric registry, you can see that the rate of sudden death is about 5% over 10 to 15 years. And there are well-known risk factors for those patients who will die suddenly. And one of them, the main risk factor, is that you have a Z-score greater than 2.6 of this ventricle during follow-up. You will have age below 14 years where you have the dilated cardiomyopathy diagnosed, and then you have a thin posterior wall which possibly reflects the inability of the ventricle to become hypertrophic due to the disease. We had this morning about the Fontan patients, and we also saw this nomenclature. And if you want to make the heart failure diagnosis, you can say that actually all the patients with Fontan circulation are in heart failure because they are unable to meet the demands of the ventricle with low filling rates. We heard also this morning that there is not really a score, but actually some people think there is a score for looking at mortality in Fontan patients. And this is out of a study where 28 studies and more than 6,700 patients were compared to the different risk factors for mortality. And you can see that arrhythmia itself, though, is a risk factor where we have a final score from 9 with a cumulative maximal score going up to 100. So arrhythmia plays a role for mortality in these patients, but it's not the main factor, as we all know, for mortality. It is well known not only for the atriopulmonary, but also for the lateral tunnel and for the extracardiac connection, Fontan, that we have a high incidence of sinus node dysfunction, pacemaker, and also for supraventricular tachycardia. If we are taking the usual measurements of heart failure, like ejection fraction, you can see that in an acute study from patients with Fontan who required cardioversion, there was an improvement of the ejection fraction in these patients directly after the cardioversion, which does not surprise so much. And if we're looking at older studies and looking for risk factors in Fontan patients for late postoperative arrhythmias, you can see that some of these studies here have surrogate markers for heart failure as a risk factor for postoperative arrhythmias. So what about those patients who do have the arrhythmia? If we're looking at those patients with arrhythmias after Fontan and compared it to those who have not, you can see that there are some markers of heart failure which are increased in those patients who have the arrhythmia. We have a higher morbidity, mortality. We have more clinical signs of heart failure. We have heart failure-related death and transplantation in these patients who do have arrhythmias. So what about Fontan conversion? If you look at the Chicago data, if you do perform arrhythmia surgery with pacemaker implantation and extracardiac conduit, what happened actually in these patients is that the freedom from arrhythmia was very good, like 77% after 10 years. So these patients do not have the arrhythmia anymore they had before. You have, though, a relative high incidence of death during follow-up, like 80% of the patients after 15 years are dead. And the interesting thing, which you can read also from this paper, is that you look at the markers of heart failure, like New York Heart Association class, like ascites or ventricular dysfunction or low cardiac output. There's even in those patients who do survive later on, there's not so much difference between the operative, preoperative, and the postoperative values. And you can conclude from that the reduction of the arrhythmia load not really does improve the heart failure in these patients. We saw this slide also in the morning. This is data from patients who were implanted primary or secondary prevention with tetralogy and risk for sudden cardiac death. And if you look at the risk factors in those patients who had appropriate shocks then, you would see some markers, and we discussed it before, with left ventricular antiastolic pressure higher than 12 millimeter mercury. You have those patients with severe tricuspid or pulmonary regurgitation and dysfunction of the right ventricle also. And I guess one of the mainstay papers here is from 2000 from Gatsoulis, where you not only can see that the rate of the ventricular tachycardia, sudden death and atrial flutters goes up with the time after repair, but you can also see the risk factors in these patients to either get atrial arrhythmia fibrillation, and the risk factor here is the presence of severe tricuspid regurgitation. And on the other hand, you have those patients who will get ventricular tachycardia or sudden death. Actually, of course, as was stated before, these patients will have reentrant tachycardias around the scars in the ventricle, but nevertheless, the severe PR is the main risk factor for these patients to develop ventricular tachycardia or sudden death. And this is also implemented in the guidelines, where you can see that it's a 2A indication for patients with pulmonary regurgitation, even if they are asymptomatic. But when they have sustained atrial and ventricular arrhythmias, they may be rather operated than not. Coming to the last group of the patients, those patients with atrial switch operations after sending or mustards, We do know from the Danish Concord Registry that the risk of sudden cardiac death is high in these patients with TGA, and it's about 4 to 5% per 1,000 patient years that you have the risk of dying sudden. And the death in this patient usually happens when these patients are exercising, and rather not when they're at rest. So when we look at risk factors for sudden cardiac death, of course, arrhythmia is a risk factor for those, but we also have risk factors of heart failure, which will lead to a higher risk of sudden cardiac death with a higher New York class, with symptoms and with severe right ventricular dysfunction in these patients. So this is actually what happens in these patients. Here you can see the tracing from a young man after stenting who was implanted for primary prevention with the defibrillator. And you can see the atrial tracing here and the ventricular tracing from atrial fibrillation, which is eventually conducted fast, so that this device gets into the fast VT zone and delivers your life-saving shock for initially atrial fibrillation fast conducted to the ventricle. And one might hypothesize that this is actually the reason for malignant ventricular arrhythmias and sudden cardiac death in these patients. You have myocardial ischemia due to remodeled right ventricular dysfunction. We have rapid ventricular rate triggered maybe through atrial arrhythmias. We have a mismatch of the O2 demand and that what is there on coronary perfusion, which all in all needs to a reduction of stroke volume and the arrhythmia. So, question back to the what triggers what? I guess tachycardia-induced cardiomyopathy. Yes, it's correct. If we look at atrial fibrillation, we can say that arrhythmia triggers the heart failure, but the other way around, it's also true. When we go to coronary artery disease, this will lead to sudden cardiac death due to ventricular tachycardia. For atrial septal defect, definitely heart failure will lead to atrial arrhythmias. And for dilated cardiomyopathy, we see this on the ventricular level. The Fontan population, I think it's a little bit difficult. We have different markers which might contribute to the arrhythmias. We have cyanosis, we have pressure overload, we have ischemia, we have hypertrophy and dilatation of the atria, and we have, of course, surgical suture lines leading to reentrant tachycardias. And I think for the Fontans, we can say that as well the arrhythmia leads to the heart failure as the other way around. For the tetralogy patient, we can see that heart failure, especially pulmonary regurgitation, leads to ventricular arrhythmia, and tricuspid regurgitation leading to atrial arrhythmias, and the muscular descending do die because of their heart failure, probably to the right ventricular failure on these patients. So thank you very much for your attention.